Good morning, everyone. I'm Marietta Mills, a professor at the University of Maryland School of Nursing. It's my pleasure to introduce Katie Wunderlich, who began her tenure as Executive Director of the Health Services Cost Review Commission in September of 2018. In that role, she has led the commission for the transition from the hospital-based Allpayer model to the total cost of care model, which focuses on hospital and non-hospital system transformation to enhance patient care, improve health, and lower cost. Previously, Ms. Wunderlich was the Principal Deputy Director at HSCRC, overseeing the Center for Provider Alignment and Engagement that works with hospitals, physicians, and other healthcare providers in partnership with patients to achieve the goals of the new model and to transform healthcare delivery. Before joining HSCRC in 2016, Ms. Wunderlich was a Deputy Legislative Officer in Governor Hogan's legislative office. She also served as the Director of Government Relations for the Maryland Hospital Association and as a budget analyst for the General Assembly's Legislative Services Department. She has a master's in public policy from George Washington University. Welcome, Ms. Wunderlich.
Thank you very much, Mary, for that warm introduction. I'm going to share my screen and go through a few slides with you all. I wish we were doing this in person. We will get back to that hopefully soon. I do want to make a couple of opening remarks as I'm sharing my screen. Sorry, just 1 minute. Okay. Everyone can see it. First, I want to thank you, Mary, for inviting me here to your summit. And I also really want to extend a very heartfelt thank you to all the nurses out there. I know your work and dedication over the last 16 months has been a huge undertaking. You have absolutely been on the front lines of this pandemic, and those of us who do not serve in a clinical capacity, I know can't fully appreciate how that is to be on front lines, but I do want to express my thanks. I know it's taken a toll on your families, on your health, on your mental health, and really want to express that folks really appreciate all of the work that you have done over the last year and some change to help fight this pandemic. I did want to talk a little bit today. This is a little bit of an overview of what I'll do. I do want to go through what the HSCRC is, the Health Services Cost Review Commission, and how our work supports the greater healthcare transformations that are happening in the state. In order to do that, we'll go through some of the details of our Maryland health model that are agreements with CMS and the Centers for Medicare and Medicaid Innovation, and a little bit about our system and COVID-19, how we've been able to position ourselves. So absolutely, we're going to be talking about how we are implementing value-based healthcare reform. That really very much depends on a vibrant and robust nursing workforce that drives quality improvements, operational improvements, care coordination, home-based care, preventive care. Really, the nursing workforce really touches all of those elements. And so we definitely feel that workforce element is a key part in actually getting the state to make care transformation, quality improvement, and cost reductions for Marylanders. So a little bit about who we are. So the Health Services Cost Review Commission is an independent state agency. Our primary responsibility is to set hospital rates. So we set hospital rates for all of the hospitals in Maryland, all of the acute care hospitals. We oversee some of the private commercial rates for the psychiatric hospitals and the pediatric hospital, but our primary responsibility is over the acute care hospitals in the state to set all of their rates. That is our underlying and core responsibility. However, as healthcare has evolved, as care is delivered not only in hospitals, but very much important to look at the upstream and downstream ways that we can coordinate and improve our system, the HSCRC is also really helping to drive that transformation across the state and across the provider spectrum. So we do really want, our vision is to enhance the quality of healthcare and patient experience, improve population health and health outcomes, and reduce the total cost of care for Marylanders. So our primary responsibility is through the hospital system, but we know that care is delivered across the spectrum, and we're working to connect all of those care partners for the betterment of Marylanders. A little bit about how we've progressed as a system. We've had an all-payer rate setting system since the 1970s. That's something that is in Maryland statute that requires all hospitals to use HSCRC approved rates and requires all payers to pay those rates. That means that all payers pay the same amount regardless of whether it's a Care First member, Medicaid, Medicare, or private pay or self-pay. So we have had this all-payer rate setting system since the 70s. It has progressed. I apologize, there's a train going by. I hope it's not too disruptive. We've progressed from a volume-based system to a value-based system, and very much other parts of the healthcare system have gone this way. We've really pushed towards a value-based system over the last 7 or 8 years, since 2014, to look at not a fee-for-service based reimbursement system, but really looking at population-based reimbursement. And that shifts hospitals' focus from one of churning patients in and out to focusing on an efficient hospital system, reducing unnecessary utilization, increasing care coordination so that patients, when they come into the hospital, have the right follow-up and discharge coordination. So there's incentive now to look at the population as a whole, and to try to treat the service area population as a whole, instead of the patients that just come into your hospital. So our unique healthcare payment system, and this of course is our hospital payment system. We call it the Maryland Health Model. It's buttressed by 2 elements on the left-hand side. One, I mentioned the all-payer rate setting system, which is a state law. The other part of the Maryland Health Model that really makes it what it is the agreements with CMS. The agreements with CMS waive Maryland hospitals from charging Medicare inpatient and outpatient prospective payments. So it waives Maryland hospitals from the CMS payment methodology, and instead the HSCRC sets that reimbursement. Some of the strengths of this model, we're really proud of how the Maryland Health Model has evolved and the very real benefits that it accrues to payers, to consumers, and to the system. First, we have been focusing on cost containment for the public. That's part of our agreement with CMS, which we'll get into in a little bit. But because we have an all-payer system, those cost containment initiatives not only accrue to Medicare, but also accrue to other payers in the system. And so that brings down our hospital costs across the board, not just for Medicare, but for everyone. We do include all payer quality health outcomes through pay-for-performance programs. So hospitals are incentivized to reduce readmissions, reduce in-hospital complications, reduce the amount of potentially avoidable admissions that come into their hospital. These are all ways that we're trying to incorporate the incentives to improve health and improve quality through the system. The model also avoids cost shifting. As I mentioned earlier, every payer pays the same amount at a Maryland hospital, regardless of whether they are Medicare, Medicaid, Care First, self-pay, uninsured. Everybody has the same hospital charges, regardless of that payer type. And so there is no cost shifting the way there is in other states in Maryland. In Maryland, all of the charges are the same. So in other states, where Medicare and Medicaid may pay below cost, hospitals may shift those additional costs that are not covered by Medicare and Medicaid onto privates. And that does not happen in Maryland. Really helps to keep the cost of hospital services down for everybody across the board. The other thing our model does is guarantee equitable funding of uncompensated care. That means that we do not have any public hospitals in Maryland. That means that any person, regardless of their payer type, regardless of whether they have insurance at all, can go and access hospital services, and they can go to anyone that's in their neighborhood that they would like to go to. So it does share the burden of uncompensated care equally across the state. Our population-based system has created a stable and predictable system for hospitals. This has been especially true in the pandemic, where hospitals have seen great fluctuations in volumes. First, when procedures were canceled, elective procedures were canceled, and then also as folks were trying to make sure there was enough room for COVID patients and keeping some other units and services lower volume so that they could accommodate the COVID influx. Our population-based reimbursement system allows hospitals stability and predictability so that they do not lose revenue based on low volumes. Really was able to produce a lot of stability in the system. It also produces stability for rural health, for rural hospitals. So we've been able to ensure continued access to care in rural areas as well. So, the other ones we're going to talk about the population health investments that we're making and the support for other state healthcare infrastructure right here on this slide. So through our rate setting system, we include assessments for support of other state infrastructure. So in addition to rates that support hospital operations, we also include in those rates we assess additional fees so that to help fund Maryland's healthcare infrastructure. I've included a few of these. One is the CRISP, Chesapeake Regional Information System for our patients. That's Maryland's Health Information Exchange. It provides a wealth of data for providers, both in hospitals, nursing homes, ambulatory care settings, to connect providers across the system. They are a great advantage and a great resource to Maryland. Part of the fees that are assessed on hospitals help to fund that system. Another example is the Maryland Patient Safety Center, which is a state designated entity that brings together providers across the spectrum to promote best practices and improve patient safety. The nurse support programs, I have a couple slides on the nurse support program to talk specifically about that. The Medicaid deficit assessment is the last kind of example. Whoops, there we go, yep. So those are some examples of state infrastructure that are able to be funded through our hospital all-payer rate setting system. The nurse support programs I mentioned, that's another one. Two programs that are funded and supported through hospital rates. The first one, the Nurse Support Program 1, is geared towards hospitals, and it's a non-competitive hospital grant, but it really helps to address recruitment and retention of nurses at hospitals, especially promoting and sustaining the number of bedside nurses that are available. There's another Nurse Support Program 2. As we went through in the beginning in 2000, when we started the Nurse Support Program 1, we realized that there really needed to be additional support and additional funding for educational faculty members to help promote and build the nursing workforce. So they created the Nurse Support 2 program. This is a program that's administered jointly with the HSCRC and the Maryland Higher Education Commission. It is a competitive grant, and it's focused on expanding the capacity to educate nurses through increasing those faculty and strengthening nursing education programs at Maryland institutions. Two really important programs, and an example, I think, of how our all-payer rate setting system can help support workforce, infrastructure, data, safety measures. There's a lot of things that we are able to cover through hospital rates that not only benefits hospitals, not only benefits patients at hospitals, but also benefits the broader healthcare spectrum in Maryland. We've also, over the last year, certainly before this, but this last year has put health equity into greater focus for the HSCRC. We are working towards, in the total cost of care model, as I'll mention, we're working towards population health and aiming at reducing chronic conditions. Many chronic conditions are felt more heavily and more pronounced in communities of color, and we really are working to establish these policies to ensure Maryland helps to eliminate longstanding health disparities and achieve a more equitable healthcare system. And we do this through a number of different avenues. The statewide integrated health improvement strategy, I'll talk about a little later in the slides, but it's the state's map to quality population health and care transformation improvements across the spectrum, very much including a look at health disparities. Our hospital quality programs are including elements of within hospital readmissions along disparities. We also we have data and hospital reporting. We've developed an internal diversity task force and collaborating with other state agencies. So very much focusing on how HSCRC through its policies can help to address these longstanding health disparities and promote better health for everyone. This is a quick slide on our all-payer model. So we have had since 2014, if you'll remember back to the progression slide, beginning in 2014, we began a contract with the federal government, with CMS and CMMI, to look at hospital cost and quality. It ran from 2014 to 2018. We had targets that we had to meet, both financial targets and quality targets, and we exceeded both of those. Just to give you a flavor, we were required across those 5 years to accrue $330 million worth of Medicare hospital savings. And in fact, over those 5 years, we accrued $1.4 billion in hospital savings. So we very much exceeded what our goal was. We also were looking at total cost of care savings. That means the hospital and non-hospital costs, which I'll talk about in a minute. We were able to keep our average all-payer hospital annual growth to below 2%. Our goal was a 3.58% rather, a 3.58% average annual growth in hospital costs. That was to keep in line with general state GSP growth. We were able to keep it well below state GSP growth, below 2%. We also had quality targets. One was to reduce in-hospital complications, and the other was to reduce the rate of readmissions for Medicare to below the national average, and we were able to achieve both of those. There was, as we moved through that all-payer model, we recognized that while there was $1.4 billion in cumulative hospital savings, there was only $869 million of cumulative total cost of care savings. So clearly there were some Part B non-hospital costs or DIS savings that were taking away from or offsetting some of the hospital savings. So while we were able to hold down and produce very significant hospital savings, our Part B costs increased a little bit. And that was a little bit to be expected because we were focusing hospitals on treating patients in the most appropriate setting. We were incentivizing hospitals to reduce unnecessary utilization by making sure they had a connection to their primary care, by making sure they had a connection to specialists, by treating them in an outpatient setting if possible. All of those contribute to additional Part B costs. So we knew that there was going to be a little bit of an offset. However, we also wanted to, instead of just squeezing the balloon on one side and having the balloon pop out on the other, we really wanted to look overall at both hospital and non-hospital costs and quality to see how we could align incentives and produce programs and initiatives that worked across the spectrum to both control costs, but also to improve quality and care transformation. So we transitioned then to the total cost of care model. This began in 2019 and it runs through 2028. And again, both of these are agreements with CMS and the Centers for Medicare and Medicaid Innovation, CMMI. This contract does look at both hospital and non-hospital cost and quality. We have some financial tests that we have to meet, and we have some quality tests that we have to meet. The first three buckets here are financial tests. The last three are quality and care transformation tests. So we do have annual Medicare total cost of care savings that we have to accrue. We have a guardrail, which means that Maryland can't grow faster than the nation by 1% and can't grow faster in any 2 consecutive years. We still have that cap on all-payer hospital revenue growth. It's still a 3.58% cap because that's the longstanding trend for growth in the state growth product, gross state product. We still have our goals for readmissions and hospital-acquired conditions and care transformation through population-based payments. Those are some of the key model targets that we have to meet. But of course, we're not just staying there. We are going beyond that. I'll talk in a little bit about our statewide integrated health improvement strategy, which, as I mentioned earlier, is our state map to improve population health, care transformation, and quality across the board. Here are some strategies that we've put in place that we've been thinking about since the Allpayer model, but really some tenets that we try to incorporate as we put together our policies. One is to foster accountability. That means putting providers in the driver's seat. That means putting providers in charge for the care and health outcomes of defined populations. We want to align incentives, both for providers and for payers, so that everyone is working together in a common direction. And that's really important, not only for hospital-based providers who are on a global budget system and non-hospital-based providers who are still on a fee-for-service system. We're working hard to try to bridge that gap by having care transformation and value-based models that bridge both the hospital and non-hospital sides so that we can align both cost and quality incentives. That also gets into transforming care. Again, as I mentioned, we're really looking at coordinating care for patients in both hospital and non-hospital settings. And then finally, improving population health. This has been a big driver in our policy development and focus in the total cost of care model to encourage statewide coordination to address chronic conditions, health disparities, and health outcomes. Excuse me. So a couple of components of our model, the hospital population-based revenue. This is our underlying global budget, GBR, global budget revenue. It is the system, the financing system for hospitals that is value-based, not volume-based. Our care redesign programs is really helps to foster care transformation across the healthcare system by expanding incentives for hospitals to work with other providers, by expanding value-based programs, not just to hospitals, but to their other care partners, and identifying areas where there's macro eligibility for participation. Another really key component, the Maryland Primary Care Program. The Maryland Primary Care Program, we think, is a key component to help drive better health outcome and better coordination. A patient's primary relationship, hopefully, is with their primary care provider. We want to strengthen that. We have a program in Maryland for enhanced fees for primary care providers so that they can offer behavioral health, longer hours, more time to spend with patients so that they can help address chronic conditions and improve health outcomes. And then finally, population health. There are three main population health areas that we're focusing on. Initially, diabetes, opioid addiction, and maternal and child health. And under maternal and child health, there's maternal morbidities and childhood asthma. So we chose those three population health areas because they are prevalent across the state, because they address health equity and health disparities, and can really drive some improvements in quality and cost reductions in Maryland. And I know I'm going through this really fast. I will have time for some questions in just a couple minutes. I just have a few more slides to get through. The statewide integrated health improvement strategy is, as I mentioned, the roadmap that Maryland is using to improve quality care transformation and population health. And this is across the care spectrum to drive those improvements on hospital quality, by reducing avoidable admissions, and by improving readmission rates for within hospital disparities. Improving care transformation, which is that care redesign that I talked about earlier, to expand value-based programs, not from beyond just hospitals to other non-hospital providers, and then focusing on those population health goals, diabetes, opioids, and maternal and child health. And the health goals are there for each of those population health areas. Very much the population health areas very much are, we need to work across state agencies, across providers, across community organizations. The population health goals that we've set for ourselves really require a broad coalition to coordinate and address, hopefully address some of these burdens. A little bit on special program funding. These are some other ways that the rate setting system can support care transformation, community needs, statewide priorities, and infrastructure development. There are a few here. Our Regional Partnership Catalyst program supports hospital-led community partnerships that address those statewide health improvement goals, so that address the SIHIS population health goals. This big long one, that's PWSDA, Population Health Workforce Support for Disadvantaged Areas, is one I'm really proud of. It identifies community health workers, peer recovery specialists, and others for community-based jobs to help support not only the hospital, but the community as well. We're looking at Medicare Advantage. We have some grant funding for COVID-19, both for partnering with long-term care facilities and now to help with the vaccination efforts. Very quickly under COVID-19, through Everyone for a Loop, the HSCRC, because we have rate setting authority, independent rate setting authority, we could act proactively. We did not have to wait for the federal government or Congress to approve those provider relief funds. So we did work to address regulatory and policy barriers, ensure hospital financial stability. We worked with other state agencies, and we really tried to, in the process, communicate as broadly as possible. As I mentioned earlier, the system really did provide financial stability through this pandemic because it guaranteed revenue. And in guaranteeing revenue, it allowed hospitals and their staff to focus on the changes that they needed to make within the hospital to take care, to prepare for, and then to take care of COVID-19 patients. And so that was really our focus, and especially in the beginning, is to take away that uncertainty of revenue so that hospitals and their staffs could focus only on what was coming. And of course, nobody really knew what was coming, when we started. So just a little bit in review, we have a very unique approach to healthcare. Our Maryland Health Model, while hospital-based through the rate setting system, we very much are broadening past that to help coordinate care, align incentives across the healthcare system. We do, through our hospital system, do want to make sure that there is an equitable distribution of hospital costs and equitable distribution of hospital charges. As we talked about, we had a lot of success under the Allpayer Model in terms of producing savings and quality improvements, but really want to continue to push on with the total cost of care model beyond just hospital-based incentives and programs to improve health outcomes and reduce spending across the board. Again, Maryland's GBR system really, it was a real benefit to the state, both in the pandemic. It's been a benefit for rural hospitals and others. It allows some stability and predictability, really a key foundation of our system, and through the pandemic as well. And that concludes my remarks. I hope I didn't go too fast. I know we have a couple of questions. But please, if there's any other questions that you have, any other topics that you would like to discuss, I'm open, and thank you again for having me.
Katie, thank you so much for the presentation. You've given a tremendous amount of information. There have been several people who have commented that the presentation was really helpful in understanding the all-payer model and understanding the systems in Maryland. And one question that was a little bit unrelated to the presentation, but it's very important, is someone had asked if you could speak to some of the rumors about hospitals receiving more money for COVID cases, thus leading to death certificate falsification. What the participant says is that they understand that it's false, but they're interested in whether there's any specific verbiage that could be used to shut it down when we hear it, because this individual works in an ICU, has worked in an ICU for decades, and knows that there's more than one disorder that can legitimately appear on the death certificate, but is kind of wondering how to best and intelligently discuss this with others who want to weaponize it and use it for a COVID isn't that bad point of view.
Yeah, it's such a great question, and there has been so much rumor, disinformation, and other things, and I think it is hard to try to shut that down. It's hard to shut down conspiracy theories and conspiracy theorists when you see them. Absolutely, hospitals have very rigorous auditing. We have a rigorous auditing process. There is also an auditing process through the state as well. So there are, hospitals can't just falsify records and get away with it. There is an auditing process. It is true that we allow the state system, Maryland state system did allow, because we're on a constrained population-based budget, which means that as volumes increase, traditionally hospitals cannot bill additional money for that additional volume because they should be managing their population and their patients and their service area within that global budget. However, when the pandemic came, there was so very much uncertainty, and we did want to allow for a hospital that was at capacity, but then had COVID cases. If there was really going to be an influx of COVID patients, we did allow them to look at that to see whether there were additional COVID patients that put them over their volume. But again, we have a very strict auditing procedure. We have a very strict auditing procedure to look over hospital records and hospital claims. We receive a lot of data from hospitals. Hospitals have to report a lot of information to both the HSCRC, the state, and to the federal government. So I think in that way, certainly if there is falsification of death certificates, it absolutely would get picked up. So I don't know of that, being the case, being rampant, but absolutely it would get picked up in our auditing.
Great, thanks so much. We've had another comment saying, this is a little bit different. The guarantee of revenue for the Allpayer and through the Maryland system didn't stop some hospitals from having to furlough or lay off workers. Could you address this?
Yeah. So this is an unfortunate side effect of the pandemic. I think there are some systems that didn't furlough any workers. In other instances, the workers that work in, or the nursing staff and other staff that work in unregulated settings, so perhaps ambulatory surgery centers or other outpatient clinics, the HSCRC guarantees revenue only on the regulated side. So that means we guaranteed revenue in hospital-based services, everything that happens at a hospital, anything that happens in a regulated outpatient setting, which is connected to a hospital. But to the extent that there is business and procedures that happen in off-campus or off-site settings, we don't regulate that revenue and could not guarantee that revenue. Now, the vast majority of revenue that hospitals receive is through their regulated setting, but there is a portion that happens outside of their traditional hospital or hospital campus. So in that regard, Maryland providers in unregulated settings, the volume drop was precipitous across the country, and it was also precipitous in Maryland. And so, now they were not able to keep all of the procedures running. I'll also say now, though, it does seem as if, nurses are in very much high demand, as you all know. There is both from the demands of the job. There is a shortage of nurses, which actually now is keeping some of the procedure rooms closed because hospitals can't staff up appropriately for all of their procedures because of demands on nursing. That's kind of another topic, but hopefully that gave a little bit of insight.
Thanks so much. A number of people are saying as well, thank you so much for helping to support nursing through the NSP2 grants. They've been very helpful to improving the number of nurse educators and strengthening the workforce. Someone else has asked, I said, please speak to the plans for total patient outcomes and cost containments associated with long-term care initiatives in community-based care in Maryland.
Yes, so that is part of the bridge that we are trying to build to long-term care, post-acute care. Absolutely something that is on our radar. The HSCRC specific regulatory authority really originates and resonates with the hospital. So to the extent that there are programs that help hospitals to connect with their long-term care providers, to improve population health, to reduce the number of unnecessary readmissions back into the hospital, to keep patients healthier at those long-term care sites. Certainly there is some initiatives to do that already within the hospitals, but that's not enough because there are many independent long-term care facilities. And so we're trying to work with other state partners, with HFAM, with other associations for long-term care providers to help enhance those value-based programs, because very much, we need to make sure we keep in mind long-term care, both residents and population health and health outcomes at those facilities.
That's great. So thanks so much. We do have a number of people who are attending the conference who are from other states than Maryland. And so one of the questions is, how would you recommend that maybe some other states incorporate some of the Maryland model into their own health systems?
Absolutely. So, what Maryland has been able to do, we've been able to do because of our regulatory authority and the coordination that we have in the state with all of the hospitals and the payers to drive value-based programs. However, there's lots of value-based programs happening in other states as well. There's lots of other ways that healthcare providers are looking at populations of people and looking at not just episodes, but how do we keep a whole population, a whole jurisdiction, county, city, how do we think about it holistically? And certainly that's happening in other states. We have seen in Pennsylvania and Vermont an exploration of those population-based budgets to that extent, to look at not just episodes of care, but really holistically, how do we approach caring for a population that distributes healthcare resources in an equitable manner, that addresses health disparities and health outcomes. And so I would say that population-based budgeting approach, while we are able to do it on a statewide basis across the whole state and with all of the payers, there are examples of that population-based budgeting being demonstrated and implemented in other states on a smaller scale, but certainly in other states they are looking at that, particularly for rural areas, to make sure that there is continued access to care and healthcare resources available in rural areas. They're really looking at that for a population-based budgeting approach.
I think that's going to be something that really does grow over time. We've already had a lot of interest, and I think people are trying to find new ways of incorporating some of the things that Maryland's done into their own systems. Mm-hmm. Another question is, how has GBR affected hospital systems' preventative testing practices? They said many of the 2016 to 2017 were hesitant to pay for routine testing, given that the payment was bundled.
Sure. So that is one of the perceptions of a global budget, is that a hospital could withhold care, or well, yes, they could withhold care in order to reap the savings, but really not address the issues that are going on with patients. And that really is a perception that needs to understand also the quality aspects. So if a hospital really truly were withholding care or not providing the services that were needed, that patient will come back into the hospital. They will have poor health outcomes. Those are all ways that we monitor and penalize hospitals based on their quality, penalize or reward hospitals based on their quality outcomes. And to the extent, if that was happening, to the extent they were withholding care, not providing the right care, not identifying a provider that could provide that care, that would come back as a penalty on their quality scores. And so hospitals really are looking at the right care and the right setting. And so definitely we are monitoring monitoring any care that is either withheld or underutilized based on those quality programs.
Okay, great. There's a follow-up question to one of the earlier ones. Is there more education to hospital administrators on how preventative testing can help address population health needs and prevent higher costs that may come with unaddressed primary care needs?
So absolutely, we are trying to educate hospitals, and certain, hospitals are large institutions, and sometimes it takes a while to get the whole culture in the right direction. But with the implementation of the primary care program, with the focus that we have put on care coordination and discharge planning, in the CRISP Health Information Exchange, there is an alert for care managers, for care plans, so that we can make sure patients that come into the hospital have an identified primary care provider or care manager, so that we can make sure those preventive services are happening, so that they don't come back into the hospital unnecessarily. Certainly, if a patient's condition rises to the level of acuity that needs a hospital admission, absolutely hospitals are there. But I think our goal is to keep folks healthy so that that doesn't happen, that we can manage health and lower acuity, hospital or patient acuity levels by making sure that preventive work is being done, by making sure patients have primary care providers, by making sure the hospital is coordinating with that primary care program and primary care provider. So very much on our mind, understanding that a lot of the work that we'll do to improve health will happen at the primary care and preventive level.
Okay, thank you. Another question, in terms of health equity initiatives, what are some examples of special program funding opportunities?
So the special funding funding opportunities. So we did a vaccination grant program that targeted that tasked hospitals with connecting with and finding, connecting with and reaching out to underserved populations, first for the purpose of getting vaccinated, but then also for the purpose of establishing the relationship with the community organizations that bridge to those underserved areas. And that will help not only with vaccination purposes for COVID, but it will also help with the continued relationship that needs to be built in communities that perhaps are hesitant to receive medical services, that perhaps receive only medical services through the emergency department. The relationship and trust that can be built through those kinds of outreach programs, I think, will help to push forward services and support for communities across Maryland, but also particularly underserved and vulnerable communities. So that's that funding. What was $12 million in this current fiscal year to start that outreach and infrastructure, or really expand on the outreach and infrastructure to underserved communities.
Okay, thank you. Another question that relates back to healthcare cost. This participant says, we know that COVID-19 has significantly changed the landscape of healthcare due to the closure of elective surgeries and decreased numbers of trauma and other injuries, plus other infectious diseases like conjunctivitis, common flu, and ED visits, things like that. This individual wonders, how did all those things overall impact healthcare cost and hospital billing, if any?
Sure. It absolutely did in fiscal year 20. So our fiscal years run from July 1st through June 30. So for fiscal year 20, the last quarter, really March 2020 through June 2020, was we saw a significant cancellation of the elective procedures, everything that the commenter was mentioning, and volumes did drop. We allowed, because we have a guaranteed budget, we allowed hospitals, we allowed a very slight increase in their rate corridors to try to bring in more revenue, but then we allowed them to roll over. If they weren't able to charge their full global budget revenue amount in fiscal year 20, because of those low volumes, because of the cancel procedures, because people weren't coming into the emergency department, we allowed them to roll that money over. And the effect in fiscal year 20 was about $1.2 billion. No, I take that back. It was over $2 billion worth of charges that did not go out the door at the end of fiscal year 20. So there was a significant amount of billing that did not happen in the end of fiscal year 20 when the pandemic began. We took into account, we said, okay, to hospitals, yes, don't worry about that. We will roll that money forward. You will be able to charge it in the future year. In the meantime, however, the federal government released provider relief funds, those through the CARES Act. In Maryland, under our regulated system, we're approximating Maryland hospitals received about a little over $1 billion worth of CARES funding. So we said, hospitals, you have this CARES funding that is available to you. However, to the extent that the amount that you have lost in 20 eclipses even the amount that the state received in CARES funds, we'll still let you roll that over. And so we did roll over a good amount of money into the next year. But your commenter is absolutely right. Because volumes dropped, because people were not using the hospital, hospitals were not able to bill their full GBR. And we're trying to roll that forward and spread it out so that there isn't a big spike increase in cost. We're trying to spread it out over fiscal year 21 and perhaps to 22 as well, because certainly there's still low volumes, low emergency department volumes in the current year. And it will be interesting to see how long that trend lasts. It'll be interesting to see in emergency department settings in particular, if this trend continues, whether patients are getting care in other places, and whether emergency department volumes still stay low. It'll be interesting to see.
It will be interesting to see how that works out as you track it and look at the outcomes. I think we'll all be interested in that. Thank you. Question, are you monitoring shifting of cost into primary care as providers aim to reduce hospital care? Is there shared savings back to the PCPs as they lower acuity levels and keep patients healthy? And is that part of their value-based revenue reward?
Yes, so we do track total cost of care. We track how much Maryland spends both on Part A and Part B. We look at it for our tests with CMS for a Medicare basis, but we do monitor what our growth looks like both on our Part A side, on our hospital side, and the Part B primary care, outpatient, ambulatory care, et cetera. So we absolutely do monitor those trends. And so we can see if there is savings or dissavings on the hospital side, or, I mean, on the primary care provider side. In terms of the shared savings, we have the Maryland Primary Care Program, the MDPCP, which I referred to in the slides, absolutely does have enhanced Medicare payments to providers that are in the system and in the program. And that is a way to increase their care management fees so that they can spend more time with their patients, add behavioral health specialists, reconcile medications, have longer hours, all of this to address both chronic conditions and to manage the health of their patients. And many primary care providers have a direct relationship with hospitals. So I think it's a large amount, proportion of practices that are affiliated with the hospital, I think up to 70%. And so they already have an underlying relationship with the hospital. We've been encouraging those hospitals to work with their primary care practices so that they can identify patients that need to be targeted, need to have more time spent with them to lower unnecessary hospital utilization, and more importantly, to improve health outcomes and address chronic conditions.
Okay, great. By the way, we're getting a number of people saying thank you for all of your responses and how helpful they are. I think that we're almost ready to wrap up. I have one last question for you, though. Are there any new initiatives that you think people should be aware of through HSCRC that you're working on now that may impact where we're going?
Well, so I would say the statewide integrated health improvement strategy, there's a couple of slides in it, but really that is what we are using to go into the future to improve health outcomes, health disparities, and population health at a wide variety of settings, at the hospital setting, connections between hospital and non-hospital, in the community through population health. And so I would say, we're really focusing on reducing the burden of diabetes. We're really focusing on coordination for opioids. The opioid addiction rate, unfortunately, and fatality rate increased through the pandemic, which is a really sad and unfortunate side effect of the pandemic. And then also along maternal child health. These are areas that we're really trying to coordinate across providers, across state agencies, to really dive down and focus on chronic conditions and health burdens that Marylanders face, and to try to attack those from multifaceted levels. And so I would think that, to me, is the biggest thing that we have going forward, moving forward. We have this roadmap to help us make progress along those lines. And it's not it won't happen just within hospitals. It's going to take community organizations. It's going to take primary care providers. It's going to take a coordination across the spectrum to really improve health outcomes.
Okay, that's just fabulous. Thank you so much. I'd like to remind everyone that the presentation and the slides are going to be available, as was indicated earlier, for 30 days. I so appreciate everything that you've done, Katie, through HSCRC and all the other work you've done over the long term. The presentation was wonderful. We really appreciate it. And we're looking forward to watching your progress as time moves forward. And I'm sure now that people have even had closer contact with you, you may get more questions. They'll be tracking you down, which is not a bad thing. We're going to take a break now. Posters are available at this time, but without the chat sessions. Remember, posters with the chat come up at 2:30. But we will have our next major speaker at 1:15 with Dr. Hassmiller, and we'll look forward to seeing everyone come back at that time. So you have a little bit of time now to do some things, take a look at what posters you might want to review. Remember that this afternoon, the presenters will be available to answer your questions live. So thank you all very much, and have a lovely time until we meet again with Dr. Hassmiller. Thanks so much.